let me thank you all for those wonderful talks. I have a pad full of questions like when does it pay to make people mad? That seems to be a recurrent theme here. But I'd like to make certain that we get hear from all the questions from the forum before we run out of time. So do we have questions around the table? Yes, Jeff.
Thank you for all four of those. They were great. And I have a couple of questions, sort of hark back to some things we heard from Gary in the first session about ecological approach and how that relates to efficacy. You know, some of you have emphasized the importance of providing a supportive context for behavior change, and then the importance of the individual's assessment of their ability to make behavior change. I'm seeing there's real potential for a disconnect between providing what we as public health people might feel as a supportive environment and someone's understanding of whether or not they can do something and what they think is going to be effective. I was wondering if you could comment a little bit about that.
I'll talk about communication of those steps, and then I'll let somebody else address the human perception of it. But in our study, we actually did code for efficacious communication, and specifically what prevention steps were mentioned, as there were several. And it was really low. The number of steps that were mentioned, even over time, was not what we would want it to be. It was, I have the data somewhere, but it was low. Oftentimes one step was mentioned or 0 steps were mentioned, but I think that was something that we can now look at and say we've got to do better next time.
It might help to think about in the context of how people process risk information and how they perceive their own ability to respond to that risk. In terms of, one of my favorite commercials that illustrates this idea really well is a depiction of a suburban family where everything's, hunky-dory, everything's going well, and then there's a burglar, right? That there's, women freaking out and kids, and they're screaming, and they're all scared. So don't worry, here's the burglar system. What that illustrates is, you heighten people's risk perception. You think you're safe, but guess what? You're not. So now I've got you scared. But here are 2 very easy things you can do to address that. That's the efficacy component. And there is actually a lot of literature that says that perceptions of risk can motivate people, but just motivating that is not enough. You have to then facilitate that. You have to help people translate that motivation to actual change, and efficacy does that. There's also now, about 40 years worth of research that shows that we actually know particular ways of improving people's sense of efficacy, and Ben Dura has done that work for many, many years. But certainly those efficacy perceptions are not born out of vacuum. They're born out of our own self-reflection in instances when we've been able to overcome challenges, we reflect on that, and we give meaning to that efficacy. So we're talking about smoking cessation. One of the strongest predictors of smoking cessation is number of quit attempts. And there too, efficacy plays a huge role in the meaning that we give to what happens when you relapse. So January 1st, you decide to quit smoking, New Year resolution. By the 3rd, you've now got an incredible craving, right? So then you pick up a cigarette. The question then is, what do you do? How do you construe that same act? Do you look at that and say, there's evidence that I cannot quit? Evidence of low efficacy, right? Or do you look at that same act and you say, damn, next time I'm not going to hang out with my friends who drink, because that's what made me do it. So do you construe that same act as lack of sufficient effort or an evidence that you're incapable of making that change? So I think we can help people reframe that same event so that they construe from that there is something that they can do. And in fact, lots of behavioral therapy is based on exactly that same idea.
Thanks, Rajiv, for breaking the swearing barrier. I feel more at home now. All right. Well, we have to know that there's a behavior that really works, and that's not always present. In fact, it's often not present, especially in the kinds of crisis communication situations that have been brought up a lot. Let's say there is a behavior that's known to work. Behavior change, of course, is hard, and communication is a weak approach. That said, having a concrete behavior that people can engage in is helpful. They will engage in alternative behaviors that may be like homeopathy, that have no benefit whatsoever and no harm, or they may also add in some harmful behaviors. I like to give the example of my husband and I, who, so I like to get a flu shot, and I feel like that's a pretty good approach. He goes and gets the flu shot, but whenever he just feels a little funky, he likes to take this little powder that was developed by a second grade teacher. And that gives it credibility. And so that's our household's way of doing this. And the science seems to support this, that some number of people like evidence-based approaches, and when they exist, they'll do those, but they may also supplement those with their own complementary approaches.
Thank you all. This is for Monique. You talked about countering and debunking the rumors. Did you get any insights into what approaches were more effective than others?
Well, unfortunately, with this project, which was a media analysis, we don't necessarily know what worked, in the sense that community members actually don't believe those rumors. What we do know is that we got to a point where our equation equaled 0, which meant we had rebuttal minus rumor, right? So a score of 0 means every time a rumor was mentioned in the media, within that same story, it was countered as, this is just a rumor, this is completely unverified. So we know that the strategy works in terms of making sure we're communicating externally that these are rumors, but I would be very excited to do the study to see how that affected public behaviors and perceptions. But in this project, we don't have that.
I encourage you to look at a systematic review, well, actually an authoritative review by Lewandowski in Psychological Science. It describes what psychologists know about how to debunk rumors and how to address them. One of the big concerns is that by restating the rumor, we reinforce it and we spread the rumor. So it takes a lot of care to address these issues as they come up. In the context of vaccination, I know that opinion leaders and public health agencies are very careful in how they speak to make sure that they don't just pour gasoline onto the fire. Sometimes they'll just die out on their own. Other times it requires people to speak that may not actually be the obvious current spokespeople. There may be various ways to get the message out that don't involve necessarily the key agency.
Yeah, thank you, Noel. And you made me think of something that I wanted to add. This is just piggybacking on what you said, but one of the reasons we know rumors, gossip are so dangerous is because even when they're debunked, many people will still hang on to them. That's what happened with the vaccine issue, right? We came out and said, that guy didn't actually have that data. He totally lied about that, but we didn't change the many anti-vaxxers' perceptions, even in the face of the debunking. So the best strategy is not to let the rumor spread in the first place. That's obvious. Not so easy, but it's obvious. In a situation as was with Liberia, the situation that was set up because of the fledgling healthcare system, the lack of trust in the government, some of the government actions such as the quarantines, et cetera, really set up a model for rumors. So I would, keep that in mind as well, that the social context matters a lot in terms of controlling these sorts of communication.
Hi, Donna Mazzette. For Dr. Brewer, you mentioned in your talk and then just now again that the risk communication is a weak intervention. And I wonder for a lot of what we deal with, there are vaccines and other things that we can use as strong interventions. But for many others, like Ebola and other emerging threats, we're unlikely to have a strong intervention. We are unable to anticipate, or we won't be able to afford to create a vaccine in advance for many things. So is there a way, do you have hope for us? I guess going back to this morning, we need the data, we need to listen, but we can't, we have to be ready, so we need the strategies. And so I'm feeling disparate, I guess, in that we need all this data, but we don't have time to get it, and we have only at our fingertips something that you as the experts feel is weak. And so I wonder, can we get to a place where the ability to affect behavior change through risk communication is not a weak intervention, it's a strong intervention for those palatable behavior changes?
I want to distinguish between the behavior that we're trying to change, which is vaccination, and then the approach we use to change that. So if we don't have a behavior for people, there's really not much to do. We just tell them what we know, we give them our best advice, and it's almost certain that we won't have a randomized controlled trial available in the 3 days after something emerges. I appreciate that. That's the reality that communicators from public health agencies are faced with frequently. So that is something that they will have to make their decision on. What is there a behavior we want to change? And if not, or if in addition, is there some belief we want people to walk away with? Those are reasonable things to try to change. If the behavior change is the main goal and we know the behavior, we know the thing that we want people to do, we should consider policy options. So in the context of tobacco control, the most effective thing we can do is we can raise taxes on tobacco. That's a policy change. Graphic cigarette, these pictorial cigarette pack warnings, that's also a policy change. So some of the most effective things we have are in the policy change arena. And when that doesn't work, there are lots of other campaigns like the Truth Campaign, fantastic, really effective, very powerful. And yet, for reasons that Jeff was mentioning, when it's done, it's done. Policy changes can have long-term lasting effects that go on and on for decades.
I'd like to add that it behooves us to think of behaviors as not being homogeneous. So we like to think about people not being homogeneous, that there's a lot of disparity in who is what. The same is true for behavior. So we don't have one approach for behavior change. It really depends on the kind of behavior you're talking about. So getting people to change a one-shot behavior, like flu, pardon the pun, is one thing. Getting people to change a very ingrained, addictive behavior that they have been engaging in for many, many years, like smoking, is quite another. So there are, you can align behaviors in the continuum of addiction. From on one side, you've got complete choice in the behavior, to other side, you've got kind of no choice. You can align behaviors according to whether they're done in a private setting or in a public setting. Are some behaviors costly? Are some behaviors, they cost nothing, right? So there isn't, I would want us to walk away from this notion that there is one formula for changing behaviors. It really depends on the context in which the behavior has been enacted, the kind of behavior it is, and what are the underlying attributes, what are the underlying characteristics that define that behavior.
Just to add a final point in echoing, I mean, I think the question is, what do you want people to do? And that's not obvious for me. I mean, I don't study Zika, for instance, but like that's not obvious to me as a lay member of the public, what you want me to do for Zika. Why does it matter that I know about Zika personally, right? And so what's the, I mean, Gary brought this up earlier, what's the outcome you're trying to push? And in that case, if that's not clear, well, you're sure not going to have big effects on the unclear outcome, right? The other thing I would say is, you know, I was drawing from tobacco, and that's on some level very different from infectious disease, in that it has all of these factors that I think make it easier in many ways to communicate about. There's no debating the science that smoking is bad for you, for instance. But there are things that I think make it more challenging. It's a competitive environment where there's an industry funded at 100 times more than advocates, right? You know, when you're talking about infectious disease, there's usually not an industry who's trying to get people infected, right? Or at least, I hope not. And so, there's different kinds of competition from different kinds of sources. But, one of the biggest challenges in tobacco and obesity and soda, all these things, is you have this industry that has hundreds of millions of dollars and you have $50. And, so I do think there's also this element of people get infectious disease, right? Disease gets in your body, it kills you, more so than how does obesity sort of affect the body, for instance. So I think looking at some of these lessons and seeing what's similar and what's different and trying to find those things that are complementary from this other body of evidence can be a useful strategy.
So thank you for the presentations, and especially Dr. Brewer. You just made me even more enamored about the idea of establishing a public health stop, drop, and roll meme. Just a couple of questions. One for Dr. Turner for clarification, especially in Africa, where it's the fastest growing telecom market. Just wondering if you can comment on the size of the weighted values of, what was the size of the population that was had access to newspapers, radio, to SMS text, and just as a quick follow-up, maybe turning the discussion on its head about changing behavior as far as the person who's receiving the messaging. So, for example, depending on who is the source of the information, maybe we can look at how many likes are they getting, or how many dislikes, or maybe empowering people who's on point with our message to help them to become a power user, and incentivizing the sources of information. Have we looked at it that way?
Sure. So I actually brought the report with me. So if you want the precise numbers, I can actually share them with you, but I don't have them memorized. However, first off, radio is the most vital communication tool in a country like Liberia, especially with the illiteracy rate. And so the radio stations that we coded for are the 4 major stations reaching most of the country. Newspaper is an interesting venue because actually it's only going to be really read by the literate Liberians, and a large segment of the population that receives those newspapers are Liberians living elsewhere in Europe or the United States, keeping them abreast of what's happening in Liberia. We did code for I think it was the top 10 newspapers. I can't remember off the top of my head. I think it was the top 10 newspapers, and we coded nearly 800 articles. So we had a good sample of them. Does that answer that? Yeah.
There are really clear strategies for how to deal with social media that are known by some of us in the room, and I'm not even going to put myself in that category. I just touch on it periodically. One of the large organizations that I work with decided to get on board with supporting HPV vaccination. Great. And then descended on them a whole bunch of deniers and skeptics and people who were really quite loud, and it wasn't clear what to do. So they looked to organizations like Every Child by Two to get support from specific bloggers and folks on social media who knew what to say and how to say it, and had a group of people who were willing to intervene in a positive way. So I agree that we should reinforce specific behaviors, as you were suggesting. We should also rely on experts and rely on their core of experts around them.
Okay, now it's safe to go. It was very striking to hear repeated by several speakers that health risk perceptions don't move the needle at all, and rather it's more behavioral and contextual perceptions. So for people like Jeff and myself working in a public health agency, we know the health risks, but we may not be as aware of what those behavioral and contextual issues would be. How do we, as these sort of medical/academic nerds, access those issues? Is it through peer engagement, building networks in the community, focus groups? Like, what are practical things that I can do when I get back home and have a crisis I need to communicate around? Who do I talk to get that list of things that I might trial and say, okay, this is going to be a more effective message than talking about a health risk?
I wanted to address the first part of what you said. a lot of our data indicates, and I'm not talking about the Ebola data, just our data generally, indicates that there's an interaction effect between risk perceptions and efficacy perceptions. Not that risk perceptions do not matter, but just that risk without efficacy is pointless. All right. And so I just wanted to make that clear. And then in terms of understanding the social, political, economic context, I would say yes, yes, and yes to all of the points that you provided. As well, there's a pretty decent academic literature on the social determinants of public health and how they might affect your efficacy perception. So you could turn there as well for free. Yeah.
I want to add another sort of part to that, which is let's take the example of indoor tanning, which from a public health perspective, it's carcinogenic. We should not encourage young women to do that. But if you go to the websites of companies that are selling indoor tanning, it's all about physical attractiveness, right? So that same issue from a public health perspective is all about health. But that's not the motivation for women who are actually going under for that. The same is true of condoms. You know, I've worked in promoting condom use in Malawi for many years, from very much prevent disease, prevent infections, prevent pregnancy kind of perspective. The way that condoms are sold, if you go to their websites, it's all about sexual pleasure, and they try to debunk the myth that no, you can still have sexual pleasure if you use our condoms. So I think how we look at the same behavior, I think that having that ability to look at it from the perspective of our target audience, which is oftentimes very different from a disease prevention kind of lens, I think that's the first step.
Yeah, last thing I would add, I think understanding the target audience, people in the room developing campaigns are almost never the people who are the target audiences, right? But and it's expensive to do big, high-profile. But I think informal conversations are one way. Observing the public information environment. I think that's what both Monique and Rajiv are getting at a little bit here. Like, what kinds of conversations are happening around tanning on social media, right? These are things that can be observed publicly, fairly low cost, and I think that's a starting point.
I'll also just pick up on the comment, I thought really excellent comment at the microphone from Dr. Inoko about establishing some kind of a cohort of people and relationships with the community. What Jeff said is really true, that those of us developing these messages are never the right people. Sometimes to an extent. FDA did a really creative thing to get around the Paperwork Reduction Act. You can only do research on, you can only involve 9 people in whatever it is, and after that it's a violation of federal law. So doing this kind of research is actually, in some ways, against what's allowed legally in our context. So what they did is they created this volunteer cadre of consultants that was everyone from the higher-ups all the way down to the housekeeping staff. And that way they got a diverse group of people. And granted, they're in the building, and so they're not as diverse as you would want, but it certainly was better than the alternative, which was just the people sitting around the table. In my own group, that's one of the things that we do is we use that kind of a cohort approach. We look at social media. And then, honestly, I just talk to whoever I run into on the street who are in roles that are not me. I talk to people who are at the supermarket. I try to visit places where I wouldn't usually go and just have a conversation. A little weird, I agree, but at least it gets me outside of the usual suspects.
Hi, thank you. It was a great talk. So I wanted to get back to the question of behavior change being difficult. And risk reduction being difficult. And I think the examples you mentioned are relate to endemic diseases and things that we do, such as smoking, vaccines, etc. So in the context of health crisis and threats, as Jonah said, when we don't have other tools, often in communication, one of the things that we are, those of us working in public health are taught and pushed to, when you communicate, think of things that you can, and people are, if you're panicky, not to say afraid, completely, worried. Think of things that you can, messages that things to give them, empower them, things that they can do, for instance, to help protecting themselves or people around them that they care about. And that part of the messages. So I guess my question to you, is there any data on that risk reduction, behavior change during crisis? Is it the same as during the example? I suspect it's not, but if you can comment on that, that'd be helpful.
I, with some colleagues at the University of Kentucky, recently did a study where we were testing risk messages to get people to evacuate during tsunami. And it is a very different context, first of all. So let's say in a risk scenario, one behavior that you might encourage of people is information seeking, right? Be learned on this topic, understand symptoms or risks or behaviors and so on. In a tsunami, you don't want people to stop and get on the internet and check things out. You want them to hightail it out of there, right? And so that takes a very different sort of messaging. In fact, we found that shorter, very terse, very clear messages of time, right? How long do you have? Severity is always important. And then a very clear behavior. Do this. And by clear, like where they should go, how they should get there, et cetera. So I would say it's more one-way communication, whereas in risk scenarios, we might engage in more conversation with our target audience.
I have a response. I'm not sure I have an answer to your question. I think of a couple different literatures, and one of them is suggesting, at least in the context of crisis communication, that we have to have a different communication style. And one of the issues is that we have to say less, that people can take in less and remember less when they're under an extraordinary state of threat. So having fewer main points to make, and we all want to make 5 and 7 and 12 points, and probably 3 might be as much. I don't know how solid the evidence is behind that, but it rings true, and what little evidence I've seen, it was convincing. In terms of an example, I was trying to think of one. What came to mind is H1N1 and the Hajj. I think it's 2009. There's a nice paper in Science that went through what they tried to do. So you imagine 2.5 million people coming from, a couple dozen countries, all centering on one place. It's sort of like the beginning plot of one of these movies that was talked about. And then they had to figure out what to do. So you get people to cover their mouths. You get people to distance socially. Well, that's not going to work when they're all trying to circle around, the central obelisk. And covering your mouth is not allowed for women during the Hajj. Well, what about hand washing? Well, the sanitizers have alcohol in them. So what do you do there? Well, then they got the imams to give a dispensation that was an acceptable thing to use. So context does matter a lot in these situations, but they also had behaviors. They identified specific behaviors that were desirable, and then they went about recommending them, and then ran into many of the issues that I was just describing.
Thank you. Ceci, do we have time for 1 or 2 questions from the audience? Yeah, okay.
Great. Thank you for a great panel. Catherine Lyon-Daniel from CDC Communication Office. I have one comment and one question. I didn't want to leave the rumor on the table unrefuted that communication at large is a weak tool. So I think some of the reasons that you bring up make a lot of sense. If the audience is truly motivated, it will work. If they're looking for information, like pregnant women looking for information on Zika, they will listen. Where I think we run into trouble is where people already know. They already have their own opinion or their own expert, and then they're really not even listening. So we can't convince them. So that's the comment, and I'm interested to hear back. The question is related to the legacy research and rumors, which is, do we now in our communication environment always need an enemy? It feels like there has to be someone to blame. And if that's not part of the motivation for change or anger or something, it seems to fall flat. And then somebody coming in with someone to blame, often industry or government, is the one that gets the most attention. I've been wondering about that and want to know what you think.
People definitely want someone to blame, and I think in the case of tobacco, it's there's someone to blame pretty clearly. But I mean, I guess I would make the point that I made earlier, is that in many cases, infectious disease, you don't have that natural person promoting it. So yeah, absolutely. I don't necessarily think that you would want to find someone to blame in that circumstance. Yeah, I I can't offer a whole lot more wisdom. Most of my work has been in tobacco, obesity, opioid addiction, places where there are large industries promoting a harmful product for profit. So,
I think people do like to have a common enemy. But interestingly enough, literally just last month, some of my colleagues at Legacy and I published a paper also looking at the more recent truth data, version 2.0, right? And we actually measured how angry the ad made them feel. How angry are you? Then we also had a proxy question for how efficacious do you feel, right? And then our dependent measure was, did you talk to people about the campaign? Did you talk to people about smoking, right? And we found that when people experienced anger and efficacy, so it's sort of that group from the RPA, it more than quadrupled their odds of talking about the ad.
So my question is about the target audience for the communication. So a lot of you have been talking about messages that are really geared towards targeting the general population, which is fantastic. I think building self-efficacy in the general population is great, but it ignores the fact that we're living in a social hierarchy and that a lot of times people's efficacy is really modified by what their organization that they work for allows them to do, what the culture is there. I think in America, we have a strong culture of power through, and if you go to show up to work when you're sick, that's a great thing. It shows you're really dedicated and hardworking. So how do we actually get risk communication targeted at this sort of middle layer, the people who can help influence that culture and sort of help us influence the risk behaviors that people are taking at that level?
Let me exert executive, and let's, since we're already eating into lunch, let's hear there are two other questions there. No, okay, all right, then let's have quick answers to these questions, and then we'll break.
I'll take a stab at that. I think that's a fabulous question. I love that question. And my first stab at it is that no matter your position in the social hierarchy, every one of us is living under a set of constraints. We all work for somebody, as someone once famously said. And so those, and you know, even for a policymaker, if your target audience is the policymaker, they're also living under a bunch of constraints. They can't just, you know, most of them cannot just act willy-nilly. So I think it's back to know your audience. What are the constraints that they're living under? You know, organizational change, literature says that what needs to be done is often quite clear. How to do it, who's going to do it, who's going to take the responsibility. Those are messy things that are much more difficult to change. But I would say that the importance of crawling into that person's head, no matter who that person is immensely important.
Okay, let me sort of thank the panel and thank the audience and the forum, and somebody knows what's going to happen with lunch. Well, first, let's thank everybody.